So I'm showing two cases where you can do without an implant and with all-inside repair. So this is the first one where you can do direct suture technique with a fiber wire without using any implant in patients where there is a financial issue and where you cannot use any implant surgery. So in these cases, you can use a posteromedial portal to probe and to look properly how is the ramp lesion. So in this, you can put a posteromedial portal. So then most important part is to rasp the lesion. So most commonly, it is a soft tissue part which the capsule has to heal back onto the meniscal tear. So you want to rasp it so to get the biology, and you can also rasp the underneath bone. So once that is done, you can use a suture lasso. You can do by two ways. Either you can use a knee scorpion or a suture lasso. But using the knee scorpion has some limitations. If the tissue is friable or if you have different directions, you cannot manipulate it. But with lasso, it's very easy. You can take a bite and you can use different angles of the lasso. Wherever you want to take a bite, you can take it. So initially, you can take a bite through the capsular, good cuff of capsular tissue. So once that is done, you can shuttle the fiber wire, and then you can come back again to the meniscal, posteromenical tissue and take a good bite within the posteromenical horn tissue. So once that is done, you can shuttle the fiber wire, same fiber wire again, and check for the reducibility. So see how far it is reducing and coming together, so that you should have end-to-end marginal convergence sort of thing. So once that is done, you can put your suture technique, whatever you are comfortable, half inches or whatever. So once that is done, you can check for the reduction, so how it is reduced well. So depending on the tear size, you can put one or two couple of stitches again, so that you directly close the ramp lesion mouth. So once that is done, if it is doing alone, then you may need to do some drill holes in the non-articular region to get the biology. But if it is done along with the ACL, you doesn't need any biology because already femoral tunnel itself gives some pluripotent stem cells. So that is the final one. This is the second case where you do all inside repair. So once the joint is completely inspected, so most of the time, if you are not doing or assessing through the posteromedial portal, so it is a high chance you miss it. So if there is any associated ACL tear, it's very easy to go back into the popliteal region, transcondylar view, so you can see clearly the ramp lesion. So once you want to assess that, so most hurdle comes the medial tightness. So always in these cases, if you are using an all-inside device, you may need to do a medial pike resting. So because it's very difficult in these tight knees to use the device and go in appropriate direction and to close the defect. So always it is best to do a medial pike resting and try to get enough space so that you can use your all-inside device. And most commonly, when you probe it, the hypermobility of the meniscus. So most of the time, so there won't be any tear seen on the body or the posterior horn, but still the meniscus will be flipping around or flopping around. So that's one sign where it shows that there is some ramp lesion behind which you cannot see from the front. So once that is done, once you do a pike resting, so you go back into the posterior region, there is a ramp lesion where you can see clearly. So once that is done, once you assess how much is the lesion that need to be repaired, so the simple thing goes as a normal meniscal all-inside repair. So you can take an all-inside device, so take a bite through the meniscal tissue and go back and take a bite through the posterior capsular tissue. So the main part comes initially is to assess how much deep you want to go and how much length you should keep your all-inside device. Depending on the different devices you have, you can assess whatever you are comfortable with. So once that is done, again take a similar bite, so almost 0.5 to 6 mm away from that, depending on the tear. So take another bite from the meniscal tissue, go inside to the capsular bite. So once that is done, you can tighten that and you can assess how far it is closing that. So that depends how deep is the tear. So once you are happy with that, so you can close that, or if you want to use one more, you can put one more stitch. So once that is done, you can assess that by tightening the all-inside device loop. So you can see that once we go on tightening that, that gets compressed and gets reduced back. So that's how we do that. So once that is assessed, we can close it.